You're now listening to Protecting Your Nest with board-certified family medicine and obesity medicine specialist Dr. Tony Hampton. For more, visit drtonyhampton.com. Welcome to the Protecting Your Nest podcast. One of the reasons why I started this podcast was to provide a weekly reminder of all the aspects of our lives we need to continuously improve so we can achieve our health-related goals. The NEST and ROPE acronym provides some guidance as to where to focus our attention because it helps us identify the various root causes of chronic disease. Our NEST reminds us to focus on nutrition, exercise, less stress, more sleep, how we think, and avoiding trauma. And as we climb the rope to get to our nest, we focus on our relationships, avoiding harmful organisms, pollutants, and emotions while making sure our life experiences that we hold on to actually serve us well. But we are not the only ones charged with helping us protect our nest. It would be so much easier to protect our nest if we had clinicians who could help coach us along our way. But imagine if your clinician has burnout. What's the chances they will have enough left in the tank to focus on your healthcare needs? I know from personal experience that on days I'm tired, frustrated, or simply not feeling appreciated, I rarely am able to be present for my patients. On those days, when I struggle to protect my personal nest, it's highly unlikely I will have the ability to protect my patient's nest. So on those days, I'm not the only one who'll suffer. It's my patients who'll suffer. My medical team may suffer, and ultimately my health system. So today, we will talk about clinician burnout. Rather, it's our docs or even our advanced practice clinicians addressing burnout will be key to having a health system where I want to work and my patients want to receive care. Today, I want you to see the world through the lens of a clinician because the quality of your clinical experience won't be optimal if we don't address the burnout that plagues so many in the healthcare system. So in order to help provide some perspective, I have asked my friend and guest, Dr. Paul DeChant, to lend his expertise. Dr. Paul DeChant, his mission is to help us learn how to reduce burnout by creating a culture of organizational wellness. He is an experienced physician executive, leadership coach, and an expert on physician burnout with a proven approach to identify, treat, and prevent burnout in the entire clinical team. He does this using lean transformation, which we talked a little bit about actually during podcast episode number 23 with Arnott Aurelio. And like Arnott, Dr. DeChant uses lean to help several professional medical organizations implement this approach to create and achieve ongoing positive results. You know, his work really focuses on helping medical group leaderships with coaching, medical group mergers and acquisitions, of course, physician engagement, electronic health record optimization. I think all the clinicians are keen to hear about that. And of course, some physician compensation plan things as well. You know, Paul, I am very excited to have you here today, and I really want to welcome you to Protecting Your Nest.
Thank you, Tony. It's fantastic to be with you. I'm very much looking forward to this conversation.
Yeah, we definitely know each other. And just like my friend Arnott, who I met in Greece doing a talk about, diet and nutrition in Santorini, Greece, I actually met you at a diabetes chronic care roundtable meeting in Indianapolis about 3 years or so ago. And it was sponsored by the American Group Association. You remember that meeting when we first met each other?
I do. Yep. Indianapolis is actually a pretty good town.
Yeah, absolutely. In fact, I just thought about it. Actually, it was one of the medical school in that town was one of the schools that was on my top three. I almost went there, believe it or not. I just thought about that and ended up in Chicago Med. But I remember we took a picture together and you were holding my Fix Your Diet, Fix Your Diabetes book. And I was holding your Preventing Physician Burnout book. And
That's
I
right.
posted that. In fact, for those who are listening, I'll actually share. I think I did it on LinkedIn and a few other places. I'll share that link to the article I wrote because I was so impressed with the talk you gave, and I was particularly impressed because I learned on that day that you also use lean as well, and I'm a huge fan of that, as you know. So let's get started by you sharing with the listeners, how you became the guy who you currently are and left your traditional clinical practice and now helping organizations with physician burnout.
Yeah. Oh, thanks for that. When I first finished my family medicine residency way back in the early 80s, I never thought I'd be a leader of anything. I certainly never thought I'd be a consultant, and I didn't know anything about lean. But I did know that when I went to my office every day, things didn't work as well as they should. And I just couldn't keep my mouth shut about that. I had to talk to people and try to start to make change. And so I got put on committees and then became chair of committees and eventually became medical director and just gradually went through a process of moving into higher levels of leadership in medical organizations. And I did that within the Palo Alto Clinic, within actually very small practices up in the mountains in Colorado for a number of years, and then at Geisinger Health in Pennsylvania, and ultimately came back to the Palo Alto Medical Foundation and Sutter Health. And over the course of all that, lean became more commonly known in healthcare. I learned a lot more about leadership and management. I got my MBA and ultimately became the CEO of the Sutter Gould Medical Foundation, which is in Modesto and Stockton in the Central Valley in California. It was a 300 physician group, reasonably good group, a very difficult place to live. This was in 2009, right at the height of the big recession then. Unemployment in that area was like 18%, and it was not a very attractive place to live from a personal lifestyle standpoint. So we really focused on creating a great professional lifestyle. In fact, we built a lean transformation around a theme of returning joy to patient care with the goal of reducing burnout while creating a healthy organization itself. And through that, over the 5 years of that, pursuing that, I was surprised by how successful we were. We actually got recognized by Consumer Reports and the California Healthcare Information System as the highest overall rated out of 170 groups in the state 2 years in a row. And we moved our physician satisfaction from the 45th up to the 87th percentile on AMGA's provider satisfaction survey. So at the end of that time, I knew that indeed lean worked as essentially the antidote to burnout, as preventive medicine for burnout. And it worked, and we'll get into the discussion here about how and why it worked that way. At that point, about 2014, I received an offer from Simpler Lean Consulting, which was the consulting group I hired to help us in our transformation at Gould. So I started working with them and became an executive coach for health system leaders around the country who were engaged with Simpler in this same process, helping those leaders understand their role and how to lead their transformations more effectively. That Simpler got acquired into IBM, Watson Health, so I had a very interesting experience, learned a lot about the IT world, and then about a year ago went out on my own. So I now have my own consulting firm focused on this same work. How do we fix healthcare organizations so that they are healthy and they allow clinicians to function effectively as they are caring for patients?
Excellent. I'm not surprised that things got better in your organization before you kind of got to where you are now, because I know what we focus on grows. And I am very thankful. like I'm sure you are, that we at least had a tool. I mean, the lean approach really has given us all a way to kind of, just have something we can kind of look at that and an approach that really helps. I think us all as we attempt to lead, and it's got to be a little weird for a doc to be, dealing with IBM, but it's kind of nice to see the lens through, see the world through a different lens. So I really appreciate all of those things. And I know that some of the people listening, and I know we'll talk a little bit about lean again, but some are clinicians and some are just regular folk trying to understand these concepts. So maybe this ideal of burnout is not completely understood. So what's your thoughts on how would you define burnout and any factors that help define what that is?
Yeah. Yes, and burnout is certainly prevalent beyond healthcare. So I'm always happy to talk to anyone about this issue. The three key manifestations of burnout are first emotional exhaustion, which means we're overwhelmed, we've given everything we can, and we've got nothing else left to give. There's just, our tank is empty, we are spent, we are exhausted. And when we get to that state, it leads to the second manifestation of burnout, which is depersonalization, which is a kind of a funny word, but most people understand it as cynicism. And it really manifests as the idea that if I'm overwhelmed and I've got nothing left to give, I'm going to start to protect myself from my organization or from my work. So in healthcare, we start to protect ourselves from our patients. And we can get cynical about patients. We can get cynical about the organization we work in. And when you put those two together, people start to feel as though they experience the third manifestation of burnout, which is a lack of a sense of self-efficacy, as though what I'm doing doesn't really make a difference. And for clinicians, I think that's often the saddest, because when we see patients, almost every patient encounter, the patient really values us and that encounter deeply. But as we're seeing 20 or more patients a day, thousands of patients a year, and we're overwhelmed, cynical, and feeling like we're not making a difference, we may not experience that patient interaction the same way the patient does. And yet we're making a difference. We just can't get that. We can't feel the way that we're making a difference. And after committing professionally to such deep levels of, physicians give up essentially the decade of their 20s to get the training they need in order to be ready to take great care of patients. And after all that sacrifice, to feel as though we're not making a difference is really tough.
Yeah, I think all of those aspects, I've seen the depersonalization in terms of, just the way the docs will comment on certain things, and I'm sure that also will impact how they interact with their patients, and they're not being a good salesperson for the organization when they share that side of them. And then this self-efficacy is really something that I've kind of gotten back even before I got a little bit more efficient, and I got some of that purpose and effort. I got it back actually because when I started doing this whole low carb thing, you're having all these moments of celebration. So I mean, even I just did a post on Twitter. I don't know if you saw it, but it was a patient who saw me and was new to me since the beginning of the year, right before the pandemic. And they had lost about 30 pounds. But the thing that was remarkable about that visit is that she said, well, what was the results of my sleep study? She had been diagnosed with sleep apnea for over 10 years. And as I read the report and got to the last line, it said normal. And she said, what do you mean it said normal? And in that moment, she was able to celebrate that her sleep apnea was essentially in remission or cure, whatever way you like to say it. But in those moments, your sense of purpose is back. But again, you can't have a sense of purpose if you're just burnt out. And I've been able to kind of integrate some of the things we're going to talk about today into my practice that has helped me. I am curious, how often are you seeing burnout as you do your work? So tell me a little bit about how common clinician or physician burnout is.
Yeah, well, it is common. There's no question. Studies have been done over the past decade or so, most consistently showing around 50% of providers and nurses are burned out, and those were pre-pandemic. And pre-pandemic, the sequelae of burnout, it leads to depression, it leads to substance abuse, it leads to family dysfunction, and it leads to suicide ultimately. And suicide rates before the pandemic for male physicians were 40% higher than the average male population. For female physicians, they're about 140% higher than the average female population. So there's 300 to 400 physician suicides a year. Essentially, we lose a doctor a day to suicide. So it's a devastating issue from that standpoint. And now with the pandemic, the pressures on clinicians have only gotten significantly worse. And there's a number of clinician suicides that have happened since the pandemic started that are directly linked to the pandemic, some of which are fairly well known. And people are really spent. We think about the emotional exhaustion, the level of work, particularly for clinicians working in the hospital. There's been a lot of overwhelm. It's a little funny because for clinicians not in the hospital, some of them have experienced actually lower levels of work. So it's not universal, depending on whether you're a physician or a nurse. It depends really on your setting and what your local workplace is like.
Yeah, I can relate to that. In fact, to be honest with you, Paul, the reason why I'm doing a podcast is because things slowed down, because I'm not a hospital doc, I'm a clinic doc. So things slowed down. And before we figured out how to do virtual visits efficiently, and it's certainly not slow anymore, I actually started watching YouTube videos, how to do a podcast, and things like that. And so it actually was a kind of a hidden victory for me because things did slow down. But you're right. If you worked in a hospital, in fact, some of our team members had to redeploy from the clinical setting into the hospital. So it is kind of a tale of two cities. And so I appreciate you sharing with us, what exactly is burnout. And, you've given us a sense of how common it is. I don't think anybody listening would have known that every day we're losing a doc to physician burnout. That's, and suicide. That's just horrible. So I think this topic is definitely timely. So now that we have that foundation, let's talk a little bit about the reasons why this burnout exists. We could kind of keep it simple and say it's COVID-19, but as you know, it was happening way before COVID-19. And so give me some of the reasons why it exists, maybe some of the drivers that made this a big problem.
Yeah. So, one of the key messages I really like people to take away from my presentations is this simple statement: the problem with burnout is the workplace, not the worker. And I say that because when we are working hard as clinicians, and we do work very hard. In fact, one of the other key messages I like to share, and I know this resonates well with you, is self-care is not selfish. So many clinicians, we go into this so mission-driven that we want to take care of others. We think that's the most important thing, and we tend to self-sacrifice. And you can do that in the short term, but in the long term, it's not sustainable. And yet we still struggle with that concept. But one of the reasons that when we think about the workplace, not the worker being the cause of burnout, is because workplaces are often tough for people working in them to actually do their work effectively. And certainly, I'm most familiar in healthcare. You think about whether it's a busy clinic or a busy hospital, and patients coming through all of the challenges that are there that make it so difficult to do the job. Like your talk with Arnott about all the defects, all the need for process improvement, and many ways that we can fix the way that workflows are that allow us to connect to our patients. the work, it's dealing in that workplace, which is so it's just become dysfunctional over time to the point where we have to be constantly vigilant and focused in order to be sure that we're giving our patients the best care possible. And we can be vigilant and focused for short periods of time. It's actually pretty exciting. You know, if a big, tough case comes in the ED, there's a challenging delivery, there's a family struggling, and we help them through that emotional crisis. Those things are very rewarding and they're great, but we can't do it constantly without any break. And what we're finding is the workplaces are so dysfunctional now, it's hard to get that break. And so it's unsustainable. And over time, that becomes the issue. And what happens in the workplace that doesn't support our ability to work well is we see 6 key drivers of burnout. And these have been identified by Christina Maslach and Michael Leiter, who are some of the original researchers on burnout. Dr. Maslach's been at this for 50 years. And it's actually been one of my great pleasures as I've gotten to know her personally over the last 4 or 5 years in this work that I'm doing. But those drivers they identified, first is work overload. It's just, I've got too much to do. And it's actually, in healthcare, we have very chaotic, time-pressured environments with information overload now as well. Prior to COVID, the statement was that medical knowledge is doubling every 73 days. I mean, it is literally impossible to keep up with in the traditional ways that we originally learned in medical school. And when we're overloaded, then we start to lose control. And lack of control is the second driver of burnout. And control is important to us as physicians. We love our autonomy. We love the ability to make decisions independently, and we should. And patients count on us to take control when there's that need. And yet, it's so hard to do in these settings. And in fact, control is one of those intangible rewards that we look for when we join this profession. And insufficient reward is the third driver of burnout. Not only things like autonomy, but professional recognition and respect and appreciation, and collegiality. Most of us have had great experiences in our training programs and working with having that sense of community with our fellow students, our fellow residents, or the teams that we work with, both physician and support staff. That socialization is really important to us, and yet. That's disappearing as well. And in fact, breakdown of community is the fourth driver of burnout. When we're disconnected from each other, that's certainly worsened for people that are working remotely. Not only was it tough to connect before because people were just so busy, didn't have time to get together. Now we're not even allowed to get together. Hopefully that'll start to pass over the next 6 months or so. But that working remotely, trying to interact over technology just isn't the same. And as we get more disconnected and we're under this pressure, we start to wonder if we're being treated fairly. An absence of fairness is the fifth driver of burnout. There's a lot involved in absence of fairness, and even more so, I think now, as our healthcare workforce becomes increasingly diverse. This is actually a topic that this particular burnout driver is a little hard for me to talk about. I'm an older white male. I call myself a pale, stale male. I'm the kind of person when I am walking into a room taking care of patients, I've never had someone question my credibility based on the way that I look. Based on my gender, based on my race, based on my nationality. Yet so much of our workforce deals with that on a daily basis. And it's a true challenge, and it's great to see the increasing focus on diversity, equity, and inclusion now in our healthcare workforce. And then the last driver of burnout is it's conflicting values. It's a question of, are my personal values actually aligned with the organization I'm working with? And as we see, and many of us are joining larger and larger organizations, a lot of the focus on these organizations is on business strategy or financial performance. And it can feel disconnected from what our values are, which are deeply being able to care for our patients. So all of those drivers that overload, the lack of control, insufficient reward, the breakdown of community, the absence of fairness, and conflicting values are contributing to the challenges we see in healthcare. And not only in healthcare, again, all of these actually are quite prevalent in pretty much every industry.
These are some good nuggets. I hope that some of the leaders within health systems are listening, because I think that thinking about all of these various aspects of the issue is very important. And man, that the problem with the workplace is not the work here. While you were talking, and we touched on this a little bit when I talked to Arnott, and he mentioned Edward Deming, and I'm looking at it now. I just looked it up. It says 85% of the reasons for failure are deficiencies in the systems and process rather than the employee. The role of management is to change the process rather than badgering the individual to do better. And it's so hard to not point to that person. So that resonates with me. And I know I learned this concept as I was learning Lean. The other thing that's resonating with me is this idea of self-care is not selfish. I'm so happy you said that. That's not the first time I've heard that. And I certainly have stated that myself to patients. And I think the challenge is that we're, so-called heroes in healthcare now. And sometimes this, the cape that they put on us forces us to want to behave like a hero and do hero-like things. And sometimes that gets us in trouble. And so all of your comments resonate with me. And I really appreciate them. And I think about my friend Arnott Aurelio again. And again, he wrote the book called Lean Thinking for Emerging Healthcare Leaders. And I do believe that you guys both complement each other. And our talk today is so critically important. And he talked a little bit about, we've mentioned Lean a couple of times, and he gave his version of what he thought Lean was. So if you could just take a moment and give us your definition of what Lean is, and just share that so we can kind of use that as a foundation moving forward.
Yeah. It's a great question because it's so misunderstood and there's an awful lot to it. When I give presentations and I tell people, Lean can be the antidote to burnout. People look at me and say, Paul, you're nuts. We had Lean come in here and Lean made burnout worse. And it will make burnout worse if it's done the wrong way. Many people have this misconception that Lean is all about efficiency, and a Lean expert or quote sensei will come in and tell you how to do things more efficiently. And that is absolutely wrong. Lean is all about empowering the people who are on the front lines doing the work to be able to fix the problems that they deal with. In fact, and I know you are not mentioned Toyota a number of times. All of us in the Lean world see Toyota as one of the key leaders and original developers and drivers of Lean. But one of the statements they have is at Toyota, it's first we build people and then we build cars. And it's developing the people who do the work because, and I think probably everyone listening can relate to this. You've come into, whether you get a new job or you've been at the job for a while, you're being told how to do things, and you ask, well, why do we do things that way? And they say, well, mostly the answer is because we've always done it that way, not because we've thoughtfully designed the work in this way and are continuously working to improve it. So the best people, and so Lean empowers people. It empowers people to fix the problems that they are dealing with through a management system and culture that fosters all of that. And it has to be very intentional. So there's a lot of, and in that work, that focus is on perfect quality, zero defects, but it's done by people empowering it. It's not done by leaders insisting on it. In fact, A leader's role is to mentor and support the person who reports up to them so that they can do their job as effectively as possible. When we think about it in healthcare, one of the things I like to talk about is how lean is principle-based. It's based on respect for people, and it's based on continuous improvement. And in healthcare, the most important person, if we talk about respect, the most important person in our healthcare organization is the patient. Because without a patient, we have no reason for our healthcare organization to exist. And the most important thing that happens for that most important person is the healing interaction that takes place between clinicians and that patient. And not just, and it's actually more than clinicians. It's doctors, it's nurses, it's therapists, it's support staff, it's frontline, it's receptionists, even EVS workers in the hospital. Anyone who interacts with a patient has a chance for a healing interaction, to reduce anxiety and worry, to relieve pain and suffering, to do a procedure that makes someone better, to educate people to be healthier. So that's the most important thing that's happening. For myself, as a family doc for practicing for 25 years, I probably had close to 100,000 healing interactions. But as I moved up the ladder of leadership and ultimately became the CEO, I could no longer do both jobs effectively. So I stopped seeing patients. And my job, I was no longer doing the most important thing for the most important person in my organization. My job was to make sure that the people on those front lines had what they needed so they could do their job well. And I did that by empowering my directors and managers and supervisors to be able to do their jobs as effectively as possible. But it's all about that process of, yes, making the work that we do zero defect and perfect, but it's done by empowering the people who are doing the work to redesign the work.
Yeah, I like this. You said we, build people and then build cars. I like that. I think it makes a lot of sense. It's kind of logical, but I think that health systems, they struggle because they have a way of seeing the world, and sometimes it's they've done the research and they've looked at the data, and the data says do this, and a lot of times that's not the answer. And when I think about our health system with Advocate Aurora, and as you know, they recently Advocate merged with Aurora, and that's in the Illinois, Wisconsin area, and I do believe they definitely understand the value of burnout, and I can see them doing tangible things. I mean, most health systems have an employee assistance program, but we also have a nice well-being of support via our mission and spiritual care, where, we've given recently, I know we sent something out to the docs and the APNs to challenge themselves to take the various burnout assessment tools. And then if you are struggling, here are the resources for you. Literally this past week, not only did they are doing things for our clinicians, but this past week, they actually are giving members recognition bonuses, which kind of caught people off guard. And I was surprised because we're in the middle of a pandemic. And as you could imagine, most of us have been financially impacted, and yet they found a way to recognize people with these great bonuses. And we started our lean journey a while ago. I was in that role as medical director of the Advocate operating system, but that system was based on lean principles, and we're planning to implement problem solving where our team members will have a chance to work towards continuously improving the organization as well. So if you're talking to the leaders in my organization, I think about our chief medical officer, Gary Stuck, who's a physician who helps to lead us. And I think about one of my good friends, Bill Santulli, who's our chief operating officer. So if you were to speak to them directly, beyond what we've done already, what do you think are important things that this organization and other organizations who are listening can do to, immediately start to work towards reducing burnout for their teams?
Yeah, it's a great question. And that the immediate part is interesting because there is this urgency. And the fastest thing we can do is implement clinician well-being work, like you talked about, the EAP, having a well-being committee, all of those, being ready to provide support, all of that can make a difference. The challenge is that it's those are helping, but they're not getting to the root cause. Those are interventional mechanisms. They're not preventive medicines, preventive interventions. And as a preventionist yourself in your clinical work, I think you could probably relate to this. In fact, I loved when I was trying to decide on my specialty. I loved surgery. I loved being in the OR, but I also thought, man, I'm just patching up mistakes that didn't have to happen so much of the time, and I preferred to go into prevention. But anyway, and in health, when you think about the workplace, not the worker, is the source of burnout. There's two factors in the workplace. One is how effectively we can do our work. In fact, there's a model out of Stanford, a model focused on professional fulfillment. And it has three key components. The first is personal resilience. I've already talked about that. The second is called efficiency in the workplace, which can sort of scare some docs off, thinking, wow, they're just going to make me see more patients and generate more RVUs. And that's not what it's about. It's about removing the barriers that we run into, the frustrations we have from being able to connect deeply to our patients. That's really when we're in our zone, when we're doing, feeling like we're doing things the way we're meant to be doing them, it's when we're deeply connected to our patients. But we only get to spend about a third of our time doing that, because we're spending the other 2/3 dealing with administrative tasks, dealing with data entry. For every 2 hours, for every hour we spend with a patient, there's 2 hours either in the EHR, the electronic health record, or dealing with other things. And that's, if we can use Lean to redesign work so that we can spend our time focused on our patient primarily, and doing whatever minimal amount of other data entry and administrivia we need to do, then we're actually going to be able to function very well. And when we've done that, we see not only are clinicians happier, our work-life balance returns, our quality improves, but we're actually more productive even though our lives are easier. And we've demonstrated this a number of times in different organizations. So redesigning the workplace is key, and there's a few key approaches to that we could talk about. But in order to empower that ability for clinicians to redesign their work, the other key component is a management system and culture of wellness. And that's where really the top level, the chief executive officer, chief operating officer, chief medical officer, and other people at that C-suite level, and even the vice presidents, and division directors come into play. That's the opportunity to create that management culture that really supports all of that. And it ties together really nicely with Maslow's drivers of burnout. That first driver of burnout, work overload, drives emotional exhaustion and relates directly to workplace efficiency and removing the barriers and frustrations we have, that extra work that we don't really need to be doing. No one went to medical school to spend hours and hours a day typing. Or I don't know if you've experienced, but I certainly did, falling asleep on the keyboard at night trying to get my notes done because there was just so much to do.
It never ends.
It's crazy. And so that we went to medical school to interact with patients, not computers.
Right.
And so that workflow redesign directly impacts the first driver of burnout, work overload, which directly impacts emotional exhaustion. But Maslow has also shown that the management system, which is the other 5 drivers of burnout, that loss of control, insufficient reward, community fairness, and values, all of that directly impacts cynicism and is related to the management system and culture in our organization. In fact, you can not be work overloaded, but you can be working in a place where you just don't feel like you fit, where you don't feel respected, where you're conflicted with the organization's goals. And you can burn out, you can have that cynicism, depersonalization manifestation of burnout without being overloaded. So they're both present. And while most people think burnout is simply I'm overloaded and I'm exhausted, the management system and culture has a huge impact. So learning to make changes there is really significant for leaders. And there are ways to do that very intentionally and effectively and positively. In fact, when we do that well, we end up with not personal resilience, but organizational resilience. And we actually develop an organization that's able to rapidly adapt to changing external environmental issues. And things like what happened with COVID, where suddenly our world was rocked and everything around us changed. Organizations that had this management system approach in place were better able to adapt than those that were not. And even without COVID, there's constant strategic and financial challenges. And again, we're better able to adapt as an organization and have a resilient organization when we have that management system in place.
Yeah, and it sounds like, and I've heard you speak about this in the past, the need to lead that initiative. So could you just comment a little bit about the value of an organization that wants to move in this direction to have a chief wellness officer or someone to kind of lead that initiative? And by the way, who does that work? Are these physicians that move into these roles, or who kind of does that type of work?
Yeah, the chief wellness officer role is a very interesting concept. And I think you have to be very careful, leaders do, when they're thinking about bringing this role into play. If the problem if burnout is actually the dysfunctional workplace and management system, and the question I first think of is, well, who's ultimately responsible for that workplace and that culture? And it is the top leadership of the organization. It is the CEO ultimately, but it's also the CFO and the COO. It's the chief medical officer. It's the chief information officer who's responsible for Epic or whatever EHR someone's working with. If all of those people are not aligned around this concept of creating the best possible interaction between a clinician and a patient and focused on what do we do to achieve that, then we're really not adding a chief wellness officer is not going to solve that problem. So that really takes commitment from the CEO. In fact, one of the reasons that we were successful at Gould and many other healthcare organizations around the country are successful with Lean, it's those organizations where the CEO is really committed to this, because we're asking organizations to change, we're asking people to change, and change is not easy. And if the leader is not committed to it and people in the organization don't know that the leader is committed to it and expecting everyone else to participate, that's too easy for people to resist and make it actually difficult for the change to happen. So it takes top leadership engagement. A chief wellness officer can be effective with that in mind, but without that, chief wellness officer should be reporting directly to the CEO. And the CEO should look to that chief wellness officer as someone who essentially is in many ways their coach and mentor about how to help lead the change of the organization. I know in your podcast with Arnott, you'd also talked a lot about the role of a coach and how that person can work effectively. There's a role of coaching for the CWO as well. If the CWO is not simply, if they're focused on is supporting resilience, that's an important role, no question. But there's more to it than that.
Okay, that's interesting. And I'm thinking about structural things, and that's why I asked you about the chief wellness officer question and these structural things that have to be put in place. A lot of these things we've learned through Lean are helpful, but as how you use them really becomes the key. And even one of the things that comes to mind as I'm listening to you are a couple of things. Like, for example, we have a diet model. And in our diet model, we have a clinician leader and we have an operations leader, right? And it just makes sense. Mm-hmm. Okay, I don't know operations, you don't know clinician stuff. So what's your thoughts on using that model and whether or not that's an effective model to help us lead our organizations?
I think it's a fantastic model for that reason. We need physician leadership, and yet physicians, it's important for physicians as much as possible to be spending their time in patient care. And as someone moves through progressions of the scope of responsibility that a physician has, there's a percentage decrease in patient care is percentage increase in management responsibility. But we can be much more effective when we have a team of a physician and a non-physician working together. And there's some keys to making that work well. One is, as much as possible, I personally insisted on it in my organization, was to have that be a one-to-one relationship only. So we didn't have an operations leader who was trying to be a dyad with multiple doctors. We didn't have a doctor who was trying to be a dyad, where the doctor is trying to work with multiple operations leader. It was a one-to-one relationship so that they effectively became a team together. In fact, we trained them together in the leadership program development so that they thought together. And any meetings that we held initially, as they were learning to work as a team, they were both present. Ultimately, one of the great things is that they become so connected and united in their approach that things get to the point where if one or the other is attending a meeting or some process, they can really speak effectively for each other, and that ultimately relieves burden. But that connection together is tremendously important, along with then how the organization reporting relationships are structured.
Excellent. And another process that we put in place. So it's good to hear, first of all, that that's a good system.
Yeah.
I definitely,
Sorry to interrupt. One
go
other
ahead.
thing. So in clinical settings, in outpatient settings, that dyad works well. In a hospital setting, it's quite often even better to have a triad where there's a nurse leader, a physician leader, and an administrative leader together.
I like that. You know why I like that? First of all, shout out to all the nurses. I'll for this moment, we'll call them heroes. But I remember when I was learning my obstetrics portion of my family practice, and I think I learned as much from the nurse. The first delivery I did was at Mount Sinai House. I mean, I walk into,
sure.
I've told this story before, but I walk into, I'm actually a medical student, right? And I walk into Mount Sinai Hospital. All the team members in OB-GYN are in surgery. And a nurse grabs me and said, "Come, you have to come deliver this baby." I said, "First of all, I haven't even read the first chapter of the book about delivering a baby, And so I walk into the room, and this patient, thankfully, she had had multiple pregnancies, so I didn't have to do anything but kind of catch, But but the nurse just taught me, and that's who we spend the most time with. In the hospitals, the nurses are there 24/7 running the show. They're probably the best people to lead the hospital. They're probably the best people to, to engage the patient. So yeah, the triad, I hadn't heard that term before, but I think that makes a lot of sense. And so I appreciate that. And in fact, it made me think about the other question, which is our process of huddles. And we do tend to we have lead medical assistants now. We learned that through Lean. And we also have nurses who kind of lead our huddles. Now, our daily huddles are great because they prepare us for the day, and we can see what's coming and prepare for it. The problem I struggle with is that, at some of our sites, the huddles are during clinical hours. And I know that maybe some manufacturing companies would have their huddle before they start their day. So your thoughts on the benefit of having huddles to discuss what's coming, but more importantly, the timing. So should these things occur before the teams get started, or because I worry that our docs and our APNs are going to be in the room with a patient and they're not going to want to pause to hear what's going on with the team?
Yeah, those are both great questions regarding huddles. I'll take the second one first. It's not so much important the timing specifically as the participation part. So the more that everyone on the team, everyone who's working in the clinic that day is on the huddle, the better. And for many organizations or many clinics, that's true. If you start before things get rocking and rolling, then it's easier for everybody to participate. In fact, when we first started doing huddles at Sutter Gould, we didn't design them so that the doctors would attend, because we didn't want to waste the doctor's time until the huddles were working well. And as they started working well, and doctors found that, gosh, things were getting better, then they started to want to attend the huddle, to participate in it even more. So you want your huddle working well. And then finding the time, so many schedules are so variable these days. I think the key is to find the best time when as many people as possible can participate. And in many cases, it is right before the day starts. But it's most important to get as many people participating as possible. Secondly, in terms of what the huddle should include, it absolutely should include preparation for the day, making sure we've got the supply we need to manage the demand that's coming at us. Looking at the schedule, looking how many patients are on the schedule, or what's the census in our unit, and what do we have in terms of staffing? Do we have our equipment, and is it working? Do we have the supplies we need? Being able to anticipate problems ahead of time so that we're not surprised by them in the middle of the day. Not every day is going to be perfect, but at least if we know what's coming, we can deal with it more effectively. Other components that I like to see in huddles, one is just a minute of recognition of team members, and maybe something personal like an anniversary or birthday, but maybe something cool that they did the day before to help a patient or a fellow team member. But just a quick recognition addresses that reward driver of burnout. Ideally, we can in our huddles also do some problem solving. What went wrong? What little thing went wrong yesterday that we don't really want to have keep happening, but it's always bothering us? That's the kind of problem. That's one of the ways we can approach problem solving. And gradually, we think of these little problems as pebbles in your shoe. And as you may have a lot of them at first, and it's really tough to walk. But as you get each pebble taken out, you can move easier, your day goes better. And lastly, reviewing metrics. This is where alignment with the organizational goals becomes important, because things like patient satisfaction, quality, safety, financial performance, access, you name it, those all actually happen by operations that are happening on the front lines. And so if we can identify metrics that actually drive success with the organization-wide metrics, and we can think of ways that we can make changes to improve our performance on those driver metrics at the front lines, and we connect the dots up to organization-wide metrics, then we're really creating that organizational resilience that's so important for the long term.
Yeah, it sounds like we're not doing too bad. I think the earlier in the day we start, the better. And I think maybe getting a little bit earlier in the day would be better. But I hear what you're saying. You have to kind of do the best you can. And I do like this idea of let's make it valuable before we expect too much. But you're right. When you can kind of share some wins and you're doing well, that'll drive engagement. And so that makes a lot of sense. A lot of clinicians, one of the things I wanted to ask you about was this idea of, when we're struggling, most clinicians will say, we just need more people, and we've already done a lot in that space where we have our medical assistants who take care of referrals, patient calls, refills, and they're completely doing that work only, and they're not rooming patients. And then we have our medical assistants who help with the rooming, and they're not having to do those other things. So we've already done that, but it seems like even when you do that, people are still looking for more people. So your thoughts on, when docs say we need more people, how do you respond to a concern like that?
Well, my first question would be, what would those people do? Because if things are already crazy and unorganized, if we just add more people, we're just going to have a bigger mess.
Right.
So the first step is to redesign the work and find ways, identify, first of all, what's everybody in the team doing that's absolutely wasteful, that we don't need to do. Get rid of that, and that opens up a lot of capacity. And, even in clinics where we've done this work, where we've redesigned the work and doctors are going home, they've got recaptured their work-life balance, and their productivity's gone up, even though their life's easier. We can do that without adding any additional people at all, just by redesigning work and truly getting rid of waste. But it takes a thoughtful approach. There's not one process. I can't come in and tell you how you should do that in your clinic, because I don't know your flow. I don't know your clinic design. I don't know your staffing. You know what's there, and you're the best person to help gradually make those changes and gradually make that improvement. One of the things we also found was when we commit to lean across an organization, there's an awful lot of stuff that's happening in the background that's also wasteful. and we no longer necessarily need as many people in some of these support and administrative roles. So we can reduce the number of people needed there, and that opens up capacity to have more people supporting the clinicians directly. In fact, at Sutter Gould, we grew the number of providers while keeping the number of clinicians essentially stable. So we had our support staff stable. So we had about 1,100 support staff for 300 physicians. As Sutter Gould grew, we got to 350 physicians. We had 1,150 support staff, maybe. But our RVUs per support staff grew dramatically. And in fact, we were able to pay the support staff more because we had the capacity to do that. We had enough finance to actually support them more. Meanwhile, we had more support at the shoulder of the doctor as they were seeing patients through their day. So it's that deep commitment to recognizing waste across the organization that frees up capacity. In fact, the very first week-long rapid improvement session we did was at the front desk of an internal medicine office that had 18 doctors and had 9 receptionists. By the end of the week, we were down to 6 receptionists, and the flow through reception was faster.
That's insane.
Yeah, and those 3 other receptionists, one went back to support doctors at the shoulder, one went on to support the lean team, and one went on to work at the reception at ortho because they had a position open, and then they didn't have to hire an additional person for that. So
nice.
Yeah. It's all about redeploying those people as you identify. You don't need so many people to do this. Let's just redeploy them. We can grow our business while we keep the number of people the same.
That's right. And I guess anybody listening who's in those support roles, we're actually redeploying. We're not lean in terms of getting rid of people. We're not doing that kind of lean. We're doing the kind of lean where we're going to put you in a role where you may add more value in a different kind of way. I like that a lot. A lot of patients fuss about, and clinicians fuss about, the medical record. And so I guess I'm curious, we know there's a lot of pain points, but just a couple of thoughts on your perspective on the EMR. What's wrong with the medical record? Docs didn't go to school to become secretaries, of course. So, just a couple of comments about that.
Yeah. So I think one of the key things is doctors should do as little time on a keyboard as possible. We should be doing everything we can to reduce clicks. One simple thing at first, and many organizations now have this, but a lot don't. If we don't have single sign-on, that tap and go card, whatever technology you call it. So if you're typing in passwords still every time you walk in a room or see a patient, there's huge waste there. There's thousands of, every doctor's probably doing 1,000 extra clicks a day if they're typing in their password. So that's a quick, easy fix. It's not super easy, but it's a huge win, and it's actually very economically effective to do that. Secondly, the data entry we do, it's important to reduce that and allow doctors to focus on their patient rather than the computer keyboard. I know you're using, I believe it's IKS. That's a virtual scribe service.
Absolutely.
I think virtual scribe services are a great way to go. There's also great work that's been done by developing teams among the support staff in the office so that you have an MA actually prep the patient for the doc, stay in the room as a scribe during the visit, and then finish up with the patient afterwards. That can actually be very cost effective as well. So that's another option. And then thirdly, what was the third option? I just spaced out on. Just personal scribe. The individual scribe, the in-office scribes. Right. Again, they all have slightly different benefits, but they all can work very well. And as long as the whole concept is finding the best way for your situation to reduce time that's truly wasted clicking away on a keyboard as opposed to deeply connecting with your patient.
Yeah, I love it. And thanks for mentioning my virtual note taking. There's certain things that happen in your life that change your life. One was when I learned how to eat right, So eating right has helped, making sure I get enough sleep, all that stuff I talk about with the Nest. So those are things that have helped. Not eating, skipping breakfast, intermittent fasting has changed my life. Learning how to reduce stress, all of those things have helped. But when it comes to being a physician, when I was fortunate to have IKS and a little tablet, I walk into the room what is called, I call it Scribble. And basically they listen to my voice, my patient's voice, and they do a tremendous job. And I really want to do a shout out to them and to Advocate Aurora Healthcare for offering that service. I was so impressed with the work they did that I published a couple of articles, one in 2019, I think around November or so, and one in February of this year before the pandemic kicked in. And I just shared, how because I have a virtual note-taking service, I'm in a master's for nutrition. In fact, I'll be studying when I finish our conversation, of course, the podcast, the YouTube videos, having more time with my patient, reducing wait times. Patients are always shocked when they have an 11 o'clock and I'm looking at them at 11:05. They're just like, wow. So all of that was possible. And I think those resources are wonderful. In fact, I'll probably in the show notes, I'll just share the information about the virtual note-taking service, ICAST, that I have, just in case people out there are curious and maybe want to talk to somebody about that in their health system. I just think that this opportunity is not to be missed. So, but let me ask you, one of the challenges I face with all the resources we have is making sure the clinicians take advantage of it. And sometimes it's a little bit of a sales job because it's different, it's new. And I think people struggle with that. And I'm just curious if you have any tips, if you were to advise me as a healthcare leader, how do I encourage my docs and my APNs if they have access to it to use these resources so that they can become more efficient?
Yeah, look, change management is a big challenge, one of the key management challenges. And the reason is change is hard for a person individually. We get used to the way things are, even if it's not the best for us. We're used to it. We're familiar with it. And the thought of moving into something unfamiliar, creates a lot of anxiety. In fact, one of my favorite management consultants is Niccolo Machiavelli, the philosopher from the Renaissance time, when he said, one of the things he said, and he wrote this book, The Prince, that people think it's a very utilitarian approach to leadership. And in fact, he's just very thoughtful. He says that one of the most challenging things to do is to try to lead change, because the people who benefit from the current state will fight you tooth and nail, and the people who will benefit from the new state haven't experienced it yet, so they're not so strong in support for you. The more people can feel and understand what the new way would be, the better. So having people actually go and experience what that new way is very helpful. And that's where, if someone came in and shadowed you and watched you, the docs who's unsure about that come in and actually see, how's this work? What's his life like? And then, realize you're going home early while they're still stuck there. That,
Right.
That can help. And it doesn't work all the time, but it's one of the key things to helping people move along. The other is to make the changes as small as possible. So maybe people test it out, and sometimes it makes sense, sometimes not. Can you test it out for half a day or for a day a week or something like that? Or give it a trial for a week or a month, but being allowed to go back to the old way if you wanted. But we found at Sutter Gould, we actually implemented this, the team care approach, where we would offer doctors 2 or even 3 MAs to support them. Now, they had to increase their productivity somewhat to financially support it, but it wasn't burdensome. And in fact, those who did had a better work-life balance. But there were a number of docs who said, no, thank you. My life is hard this way, but I don't want to change. And, that's part of it is human nature.
And I think there's always, it's just like the stuff I talk about. I've had a vegan on, Dr. Terry Mason. I had a carnivore on, Amber O'Hearn, in the last podcast. Completely different, opposite ends of the spectrum. But guess what? Some people do just fine with vegan. Some people do just fine with carnivore. So I think the key is to know what your options are and to pilot what may be the best option for any of us. So I think that makes a lot of sense. And so I appreciate that. I just wanted to get some tips because I struggle with that, and my life has changed, and I'm almost like sad that other people can't, see the value in something like that. So, because again, all the things that I'm doing would not be possible if I didn't have a great tool like that. So I appreciate that. And I am curious also, once, like I told you earlier, we're going to be piloting and starting our problem solving, not piloting, we're just going to start problem solving. And that'll be a great way to figure out what needs to be better. And I particularly like the fact that you said, things are, it may be different. So you may have to, understand what's best for your particular location based on what's going on there. So in terms of being able to cascade things out like this, so, is it, once you figure things out, is it okay to cascade things out, or do we have to come up with a different model because, you have different ways of doing things at different sites?
So I think you're talking about like you have a pilot site where you implement some significant changes and then you want to spread that to other sites.
Exactly.
So a few things that can help with that. One is certainly, being very clear about what that redesign is and defining that as a quote standard work process so people can understand it clearly. Another thing that helps is to have people from the other sites actually participate in that work redesign. If they have a team that's going to spend a day or a few days redesigning something, it doesn't always have to be the doctor or the nurse or the front desk staff from that pilot site that's on that team. You can bring in people with similar roles in other sites as they start to learn that experience, that opens their minds and their receptivity to bringing that into the other site. And then the third thing is this whole concept of best practices drives me crazy because a best practice works best in that location. And then if you come marching in and say, well, here's the best practice, you guys do it this way, it's not respecting the people at that site and what their challenges are. So there may be, the pilot site finds the way and the core concepts of that way are actually great. But how it will be implemented into that specific other site where the staffing might be different, the physical layout of the office might be different, the patient complexity might be different. Those sites then will take that and adapt it to their specific conditions rather than having to adopt it 100%. And using your huddles then as you go to start adapting that new process to understand, well, okay, let's look, we started adapting this today. Tomorrow in our huddle, we're going to look back and say what worked, what didn't, how do we continue to refine this so it works best for us?
That makes sense. And I guess one of the questions I want to throw at you similar to this is sustaining that change. So, I think that's sometimes difficult. You have these new processes. Everybody's like, this works really well, but we're creatures of habit. And sometimes you kind of slip back into your old ways. So any tips on how organizations can sustain change once these new processes are put in place?
That's a great question. And it's a really key component for leader standard work, is that the leaders, whether it's a supervisor, a manager, director, that they're aware of what those new processes are. And there's actually very formal lean processes by which to define that standard work and then have others observe somebody doing the work to see if they're actually following it. And if they're not, the question isn't what's wrong with that person that they're not doing the standard work. The question is what's wrong with the way we've designed this, that it's not easy or automatic for the person doing the work to do it that way. It's always the question isn't if something didn't get done, what's wrong with the person who didn't do it? It's what's wrong with the way we as leaders have designed this so it's not doable. And when it's with that approach, then we're supporting the people who do the work. And it's a tough concept to overcome. I mean, nobody, the thought of having somebody watch me do what I do and then point out where I'm not doing it as well as I could. If you're really advanced, you can deeply appreciate that support. On the other hand, you can feel like you're being judged. You can feel, resentful, about that if it's not approached in the proper way.
Gotcha. And I could imagine all the things we've talked about in terms of, how we we recognize there's a problem, we do things to improve things, we learn how to sustain change. But if I'm a frontline employee, a clinician, what questions should I be asking myself that'll help me know my organization is serving my needs? Or the things I need to be thinking about so I can kind of help the organization help me? What's your
Wow.
thoughts on that?
That's an interesting one. I might have to think about that a little bit. I guess one thing would be just to start with, how am I feeling? Am I, do I feel connected or not? And if not, what can I do to make a difference there? And
yeah, it sounds like we're in a marriage now, and I guess we are.
Well, it's true. And sometimes it comes down to understanding, well, what is my span of control, or my span of my span of actually, there's somebody, one of the great thinkers in Lean, particularly around respect for people, is a gentleman, Bob Chapman, who runs a large industrial manufacturing company called Barry Waymiller. He's written a book called Everybody Matters that talks about treating treating everyone in the organization with the same care and concern you have for your family members and close friends. But he talks about this concept not of span of control, but span of care. Within the realm of the people I'm interacting with or I'm responsible for, what can I be doing? How are things going with them? What impact do I have on them? And so, even if you're the frontline clinician, or the frontline support staff, you certainly have impact on the patients that you're caring for, as well as the people that you work directly with. And just being open and aware of that. And then when things don't feel right, bringing those problems forward. Daily huddles are a great place to bring those problems forward. Also, when you have a regular check-in with the person that you report up to, finding a way to bring that up as just a care and concern. This was a struggle for me when I was early in my career. If something wasn't right, I could easily get upset and angry about it, and become pretty vociferous in my description of how everything was screwed up. And it's been a long lesson for me in how to approach those things in a way that gets the importance of it across, but also builds and opens a door to have the discussion rather than builds a wall that people don't really want to hear from me anymore.
Wow.
That's tricky.
That's cool. That I don't know if I think you may have seen. It sounds like you did see the YouTube video with Arnott, and
Yes.
I don't know if you remember because you said Gary wrote this. Everybody Matters,
Bob
right?
Chapman.
Is it Bob?
Yeah.
Okay, got you. It's
Yeah.
Bob. Okay, I'm gonna look that up. But if you recall from that video, I read some words from an article by a guy named Chris Moore, and it was called Leadership Matters. And it sounds like a very similar philosophy and approach. And it's so for those who are listening, definitely look up my name and Arnott podcast episode, I think 23. And we talked a little bit about the why people matter and why how you lead matters at home, it matters at work, and it matters how you lead yourself. So all of those things are really critical. So that's something I'll be checking out myself. So, and I guess second to last question is, now, I hope to have leaders in my health system listening to this podcast. I hope clinicians are listening. But if you were to, just say what would you say to them? Again, like what's kind of something they can do to really get to understand. I think you kind of touched on the importance of kind of understanding what's happening on the front line. So what kind of things can they do to kind of make sure that to see where the problems are and to help understand what they need to do?
First thing I would say for leaders is, I have a lot of empathy for leaders as well. There's a leadership burnout as much as there is, clinician burnout.
Let me say this real quick before you comment. I remember, I'm not making this up. I remember before I kind of started getting into the leadership roles, and, and it was so funny because in my brain, the executive folk were just kind of like, they had it easy. My brain was like, oh, you got it easy. And we're the real hard workers are the doctors. And then one day I was talking to one of my vice presidents, and he was like, yeah, it was like his third or fourth night where he didn't get home to 7 or 8. And with this merger with Wisconsin, you got people driving from Illinois to Wisconsin back and forth. Now, not so much now with the pandemic, but beforehand. And I think the perception is that it's easier for those guys at the top and gals, of course. And it's just not true.
Right. No, there's, but in reality, 10 years ago, it was easier for many of them. But over the last 10 years, it's gotten much harder. So first of all, respecting that indeed, it's tough. And just as the workflow at the front lines has a lot of defects and waste, the workflow in leadership has a lot of defects and waste. And so leaders can create capacity by and having that kind of coaching like Arnott does or I do to help leaders work through and reduce the waste in their leadership processes can have a huge impact for them. And can open the capacity to do the thing that when people ask me, particularly when I'm talking to leaders, what's the one thing I could do next week when I go back that'll make the most difference? I tell them to go shadow clinicians. That is, find 2 hours a week and schedule it into your schedule where you go and shadow a clinician. And there's a process of doing this intentionally with preparation and follow-up that it works very well. But by learning, by going and seeing, actually understanding what's happening at the front lines, what the impact is of leadership decisions that get made, it creates both a deeper understanding as well as a deeper sense of urgency to fix these problems. One of my concerns for a long time has been that we haven't really pursued change with enough urgency. And before the pandemic, because burnout is miserable, and half the docs are burned out, and yet there's this not that same sense of urgency that there is when there's a crisis. When the pandemic came along and we faced an existential threat, we realized we could change a lot more quickly than we ever thought we could. Turning ASCs into ICUs, switching from in-office to telemedicine. We never thought we could do that, and certainly didn't think we could do that in a week. And yet we did.
That's right.
Facing that threat, using things like command centers and a lot of intense communication to get there. As the pandemic starts to wane, and it will again, my fear is that sense of urgency will also wane, and people will go back to the complacency they had before. But there's still going to be significant burnout at the front lines. And there's still going to be people suffering from depression, from substance abuse, from suicide. To lose our sense of urgency will be a real tragedy, because now we know that we can change rapidly. And if we don't maintain that awareness and those mechanisms in that process, that'll be a real loss.
Yeah, and I appreciate your response, going to see what the clinician goes through. And when I was the medical director of the Advocate Operating System, my vice president did come and shadowed me. And all he did was he didn't say anything. He just kind of hung out. And man, when we talked afterwards, he was like, I don't know. It was a half a day. I think I had like almost 30 people on the schedule. He said, I don't know how you do it. And I said, I don't either, but it's like, I just do it because you got to do it. Like you said, when you have to do things, you will. But yeah, I think I hope leaders are hearing. It's one thing to come visit the site and people try to polish the site up and kind of accept the leader and then they leave. It's another thing to sit at that or do the role that some of the team members do, or to actually just literally like be in the moment and not just greeting and shaking hands, but do my job, or watch me do my job. I think that's a whole nother level. I learned that with Toyota. I know they use Gemba, go to the Gemba. That's a Japanese term talking about going to the real place where the value is created. So I think that those things are really critical. So I really appreciate you. I hope people listening, rather they're clinicians or the people receiving care, that they really have a better perspective about what life is like on the front lines of healthcare and the challenges that we face, and that we now have some valuable tools to help us. So I know I mentioned as we started, a little bit about the acronym, the nest and the rope. And I don't know if that was a new term, that new to you or not, but I want you to think about that and tell me, for you personally, rather it's nutrition, exercise, stress reduction, sleep, trauma, avoidance, or how you think, or your relationships, organisms, pollutants, life experiences, our emotions. What types of stuff do you plan on focusing on in 2021 as we enter a new year?
Well, first of all, before you sent that to me, I wasn't deeply familiar with that, and I love it. I think that those two acronyms are great. For myself, I've been, this pandemic year has been an interesting one. I've working as an independent consultant. Consulting kind of just dried up completely because health systems had no money or time to deal with consultants, and even when we were offering opportunities to make great change. So it's been a lot of reflection, a lot of development, and all of that. Now, going into 2021, through all of that work, I've been able to put together a team of other consulting firms that address a lot of these key drivers. So I'm looking forward to being able to actually offer something of far more value that we can specifically design for systems when we get that opportunity. Personally, I'm working on exercise, and I'm finding I'm sleeping much better just by a few things. I've cut back on alcohol. That made a big difference in sleep. And then probably the other thing is just my relationship with my wife. I've been between whether it was working, those hours where you're gone until 8 or 9 at night doing meetings, or as a consultant on the road where I'm gone for days in a row. We haven't spent this many nights together in a row, probably maybe ever. Certainly this many days and nights together in a row. So that's been it's been great. We've had the time to connect better, to get to know each other better, and looking forward to that continuing to enhance as well. Even if things do open up and I'm traveling more, we still have that now as a base to build on.
Yeah, if the relationships, I tell my patients all the time, if the relationship is not good, your blood pressure is not going to be good. Your blood sugar is not going to be good. So making sure we, make sure that's strong is important. Just like anything, you have to work on the things that you want to be better. So I appreciate that. I appreciate all your time today. It's been a nice discussion. I'm in love with this approach, this lean approach. And I'm so happy that you're out there trying to improve the lives of so many clinicians who need to hear your message. And what's the best way for people listening to kind of reach out to you and find you in the virtual
world? That's
world?
Great. Thanks for asking. Yeah, there's a few ways. I have my website. It's pauldechantmd.com. So you can find me there. And I also I'm active on Twitter and LinkedIn. Just on LinkedIn, just look me up, Paul DeChant, MD. And on Twitter, it's at Paul DeChant, MD. So I'm there at all those places. And you can just reach out to me directly by emailing me. My email address is paul@pauldechantmd.com. And I'd really welcome any opportunities to connect with anybody who's listening in.
Well, that's excellent. I know we've been kind of keeping in touch periodically that way, and I really am, very happy we have this relationship, and it's just seeing the world through a similar lens. And I appreciate the work you're doing, and I'm going to try to do my best to do the things I do to add value. You're kind of doing a different kind of wellness, and but I appreciate that. And yeah, I think and going back to what you said about exercise, I have an every other day model. And my goal is, I don't care if it's 10 minutes or 30 minutes, I'm going to do something every other day. And I think if you just get started on most days, you'll get there. So thanks for sharing that. So any final thoughts before we wrap up?
First of all, I deeply appreciate the opportunity to talk with you and share this with your listeners. So that's fantastic. And I think the key message to take away, if you're feeling burned out, the problem with burnout is the workplace, not the worker. It's not your fault, but you have a lot of opportunity to help improve your workplace. If you're a leader, taking advantage of those opportunities around redesigning workflow and changing management system and culture creates that organization the organization is resilient and can adapt to changes happening externally. So there's so much value in that. And lastly, remember, self-care is not selfish. So take care of yourself.
Yeah, best quote, and absolutely agree. So everybody write that one down. So thank you, my friend. And as we wrap up, I just want to say, today we walk away from our discussion with more hope of a health system that our clinicians want to work in and our patients want to receive care. We now more clearly understand that we must not just protect our own nest, but continuously work towards processes that protect the nest of our clinicians who are providing care. So what better time than now? Maybe all health systems need a chief wellness officer whose only focus is to ensure that every team member is well cared for. And rather it's Arnott Aurelio's book, Lean Thinking for Emerging Healthcare Leaders, or our today's guest book, Preventing Physician Burnout, we now have foundational tools to help us as we work towards our true north. So if you're a patient who's concerned about your clinician, maybe gift them this podcast, or maybe even Dr. DeChant's book for the holidays. What better way to show you care about them? And another way is, just to acknowledge that you appreciate them, that you're with them, and that you will support them as they are trying to walk towards efficiency. So as we end this episode, promise me that you will continue to grow in knowledge every day on your way to optimal health. And as always, continue to live well and protect your nest. You've been listening to Protecting Your Nest with Dr. Tony Hampton. For more, visit drtonyhampton.com.